We'll record this session. So we're going through an extrinsic review of extrinsic applications. So as we move forward, I'll talk about the different components involved, and hopefully you'll bring forward any questions that you might have. Again, bringing up here the terminology page. You guys should, is there anything on this sheet as we start out, any references that anyone would like clarification on before we even get started? I'm forgetting, okay, sarcomers are the individual little blocks that where contraction occurs within the muscle. So a sarcomer is comprised of your myosin, your actin, troponin, and tropomyosin that play a role in creating muscular contraction within a muscle. So there's a whole chain of sarcomers together that will generate your muscle fiber or create your muscle fiber, which is then encased within the membrane of the muscle itself, or of the muscle fiber itself. Piezoelectric charge, any time that any kind of traction is put on something, whether I'm pulling on a muscle or pulling on a piece of cloth, what happens when you put tension on something is it causes for an electrical charge to be generated along the line of that pull. So this is referred to as a piezoelectric charge. In a muscle fiber, piezoelectric charge has an ability to cause collagen to spin tighter in the line of pull. What helps it, the muscle fiber, or the strands of collagen that we want to remain in position after treatment, the piezoelectric charge will cause them to spin tighter, so it's easier for us to break off the cross bridges that are not in the line of pull. Hopefully that answers your question as to what piezoelectric charge is. So a piezoelectric charge is very important in the application of extrinsic techniques, and it's also the reason we want to have some degree of passive stretch on a muscle when we go to apply our extrinsic techniques. Okay. Anything else on this page that you'd like clarification on? Okay. All right. So you can be guaranteed that on your exam there will be questions from this page asking for clarity as to what is, for example, what is extrafusal fibers, what is tone, those sorts of things will all be some of the questions that you'll see on your exam or next test, CBA. So again, going through the muscle structure, everybody should be aware of what extrafusal fibers are. They're muscle fibers that are primarily comprised of sarcomers that are responsible for creating the contractile component within a muscle, or creating the force that allows things to move. Those extrafusal fibers are monitored by a structure called a spindle, which is located in amongst those fibers. Its outermost component is attached to the fascia of the surrounding muscle fibers, and contained inside of the spindle are small strands of interfusal fibers. Some are called nuclear chain and others are called nuclear bag. The difference between those two is that the nuclear chain ones are relatively long and thin. The nuclear bag ones are swollen in the central component of them. And we have two specialized receptors that are found within that spindle. One is called the flower spray, and the flower spray is constantly sending an impulse to the spinal cord as long as there is tension on the muscle. Whereas the annulospiral only sends an impulse at the very start of a stretch on the muscle fiber. So the spindle overall is responsible for monitoring the length of the muscle fibers or the overall muscle. The other muscular component is the tendon, and the tendon is a result of strands of fascia coming from each of the different muscle fibers. They unite together to form into a singular tendinous type component which attaches onto the bone tissue, and located where the muscle fibers end and where the tendon starts or is proper is a structure called the Golgi tendon organ. And the Golgi tendon organ is responsible for monitoring contraction in the muscle. So as the muscle contracts, it pulls on the tendon, and that squashes down on the GTO and causes the GTO to send an impulse to the spinal cord. So muscular-wise, those are the components, necessary components of a muscle that we need to know. Does anyone have any questions about any of those components? Anything you don't understand, anything you've read that you're confused on, anything along that line? If not, we'll move over to the nervous system. So the components you need to know for the nervous system are your afferent neurons, which are comprised of your the spindle is the structure that contains the afferent neurons for flower spray and annulospiral. You have the GTO, which is located in the tendon, and then you have mechanoreceptors, which are primarily high concentrations of them underneath the skin. However, they are in fact throughout the entire body. You will find mechanoreceptors. And then in regards to the spinal cord, we need to have an understanding of gray matter. And the other thing we need to know about gray matter is that it is comprised of association or interneurons that are unmyelinated. That's why the gray matter appears gray, and versus white matter in the spinal cord, which is myelinated nerve cells that carry impulses to different levels. So we need to know about gray matter because that's where the communication is going to occur that we talk about from a massage therapist point of view. The last thing is your efferent neurons. So whereas afferent neurons are carrying impulses towards the spinal cord, efferent neurons are carrying impulses away from the spinal cord to generate some form of effort. And the ones that we primarily discuss or reference to for massage are the alpha and gamma motor neurons. Alpha motor neurons go to extrafusal fibers, and gamma motor neurons go to the interfusal fibers within the spindle. You need to have stimulation to both of them at the same time to assure that they stay in synchronization with one another. So everybody has a general understanding of the nervous structures that we're going to need to discuss. So I'm just going to flip through the next series of PowerPoints relatively quickly because it's just going through exactly what I just got finished saying. If you have a question, please bring it up. Either bring it up by way of chat or bring it up, flip your microphone on, and you can feel free to ask a question openly. So again, here we're just showing where your mechanoreceptors is a high concentration of them under the skin. Techniques such as effleurage are extremely beneficial in manipulating those mechanoreceptors, which will in fact reduce pain and can have an impact on reducing sensitivity within an area of the muscle or of the body, and also can help to reduce contraction in a muscle. Again, this is just referencing to the parts of the muscle. Here we can show in the top picture, it shows typical muscle. And then we've broken it down into a muscle fiber. So you can see inside the muscle fiber, there's many fibrils contained within it to form the muscle. And then, again, looking at the individual sarcomeres and that sort of thing found within the muscle fibers themselves. Your muscle is comprised into bundles, and they are stimulated to contract by way of nerve impulses coming along motor nerves from alpha motor nerves from the spinal cord. Here we have a muscle spindle, and you can see it almost looks as if it's a cocoon found within the muscle fibers themselves. Right? It's comprised by the periosteum or the fascia of the extrafusal fibers, and because they are, the outer component is made up of this fascia, whenever there's a change in the length of a muscle fiber, then the spindle will be pulled on, causing either tension to be created or actual stimulation from the annular spiral just at the very start of a change. So again, inside the spindle, we are showing here the different types of nerve components. We have the flower spray, which are located more so on the ends of the muscle fibers, interfusal muscle fibers, or on this what's called the nuclear chain type muscle fibers, small ones in diameter. And then your annulospirals are wrapped around that swelling in the nuclear bag fibers. The reason is because it allows them to be more sensitive by wrapping around the nuclear bag. So you may have any questions about the general structure of the spindle. One of the important things to walk away understanding is the flower spray component only sends an impulse when there's tension when there's tension on the muscle spindle. So as long as there's a little bit of tension on the spindle, pulling it in opposite directions, then the flower spray will fire. If for some reason the tension is removed from the spindle, in other words, there's no stretch on either end of it, then the annulospiral would stop sending its impulse. Pardon me, the flower spray would stop sending its impulse. The annulospiral only sends an impulse at the onset of a stretch. So the important thing to realize, flower spray is always sending an impulse. Next structure you have is Golgi tendon organs. They're located in the tendinous component of a muscle, and they're responsible for picking up on stimulus when a muscle contracts. So as a muscle contracts and shortens, it pulls on the tendon, which squashes the Golgi tendon organ, resulting in an impulse to the spinal cord where it communicates with an association or interneuron. questions along any of that stuff? No. Okay. Spinal cord. In your spinal cord, you have gray matter surrounded by white matter on the outside of it. The gray matter is comprised of hundreds of thousands of interneurons that are unmyelinated. And on the outside, you have what are referred to as ascending and descending pathways, or in other words, neurons that are myelinated, allowing for faster impulses to upwards towards the brain or downwards towards different levels of the spinal cord. So inside of the spine, in the gray matter, there's a region of the gray matter called the substantia gelatinosa, which just simply means a region of the spinal cord or of the gray matter, and that is where the communication for proprioception primarily occurs, is within the substantia gelatinosa. So it's just a reference to that area of the spine. Contained in there would be your interneurons that have the ability to release glycine, and by so doing, block any impulses to alpha and gamma neurons, and as a result would stop any impulse to the muscle to contract. Here we have a typical example of a polysynaptic reflex. So we have sensory receptors picking up stimuli in the skin in this example. That information is transmitted along the axon and dendrite, or dendrite and axon, towards the central nervous system, where it can communicate with an interneuron, and that interneuron will then communicate with the next motor neuron, causing a transmission back towards the muscle, causing it to possibly contract. So this would be a typical example of a reflex. So once again, I'm going to ask, is there any questions with any of these components? Everybody has an understanding what sarcomers are and what their function is. We understand what the musculotendinous junction is. We understand what the GTOs, how they play a role in things. And then we have the spindle, which is comprised of interfusal fibers. And on those interfusal fibers are two specialized receptors, one called the flower spray, one called the annulospiral. The flower spray is constantly sending an impulse to the spinal cord, and the annulospiral is only sending an impulse at the onset or start of a stretch or change in the length. So that's kind of taking us up to the sensory information, and then you have the motor information coming out from the spinal cord. So communication with the alpha motor nerves carries an impulse to the extrafusal fibers, causing them to contract. At the same time, there is a communication with the gamma motor neurons, and that allows the interfusal fibers to also contract in synchronicity with the extrafusal fibers. So a muscle only has the ability to do one thing. It can only contract or not contract. Pardon me. A muscle fiber has only the ability to do one thing, contract or not contract. It doesn't partially contract or halfway contract. It either contracts or it doesn't contract. Right? So if there's no impulse to the muscle fiber, then there's not going to be any contraction of that muscle fiber. Here again, we're showing an example of, this would be of a stretch reflex. So here we can see the spindle is, the muscle is changing in length, it's being pulled on, and this is picked up by the annulospiral, which sends an impulse to the spinal cord where it communicates directly with alpha and gamma motor nerves sending an impulse back to the extrafusal fibers as well as to the gamma neurons, causing contraction to occur within the muscle. And that would be referred to as a stretch reflex. So the primary function of the spindle is to prevent the tearing of the muscle bellies or muscle fibers. So if a muscle gets stretched too quickly, there's a chance that there could be damage to the spindle itself or to the muscle fiber itself. So the muscle picks up on that and kind of puts the brakes on, stopping any exaggerated stretching of that muscle fiber, or trying to do. Damage can still occur if there is excessive, if the contraction of the muscle is overpowered by some external force. For example, here we can see they're using the reference of bricks being held in the hand. So if those bricks are so heavy that they can overpower the contraction coming back in the muscle, then that muscle could still be damaged, possibly. This is talking about the GTO effect. So here we have, as the muscle contracts, we have the GTO being stimulated. That is then sent to the spinal cord, where it communicates with an interneuron. The chemical that it releases at the interneuron is acetylcholine. Acetylcholine causes depolarization of the interneuron, resulting in the release of its neurotransmitter, in this example, glycine. So glycine is released at the alpha and gamma motor nerve sites, and glycine causes hyperpolarization of the alpha and gamma motor nerve, thus reducing contraction in the muscle. So that would be tendon reflex, referred to as a tendon reflex. Some textbooks, yep.
Where is, again, the acetylcholine released?
Acetylcholine is released from the neuron traveling from the GTO to the interneuron. So it is released in the first stage of communication. So as the impulse arrives at the spinal cord at the association neuron, that communication is a result of acetylcholine being released. Okay. And acetylcholine causes depolarization of the nerve, resulting in the release of glycine. Okay. Anything else on that? Okay. Here is another example we're using, but instead of using the GTO, we are using the mechanoreceptors. So here we can see the mechanoreceptors under the skin. They send an impulse to the spinal cord, where it again communicates with interneurons or association neurons, and that communication is also by way of releasing acetylcholine. Acetylcholine causes depolarization of the interneuron, causing the release of glycine, resulting in hyperpolarization of the alpha and the gamma motor nerves, thus reducing muscle contraction. So exactly the same. GTOs and mechanostimulation are in fact the same thing. Does anybody have any questions on that?
I have one. It's a bit terminology related. Is there a difference between interneuron and association neuron?
Nope, they're interchangeable terms.
Okay, thank you.
All right. Anything else? Okay. So the next thing we need to have an understanding of is tone in a muscle. So tone is defined as the amount of contraction that is sustained in a muscle to allow it to maintain its shape and general function. So the amount of tone in a muscle, it needs to be stabilized in order for the muscle to maintain its shape and be prepared to be called upon for action. So how this tone is established is by multiple motor units communicating with a muscle. So within any part of a muscle, you will find multiple different motor nerves or motor units communicating. And this is what allows for some motor units to be turned on while others are turned off. That allows for a muscle to maintain tone or maintain contraction without becoming over fatigued. So that's how tone works. So there should be a certain degree of tone in all muscles. This is just describing what a motor unit is. You guys have all studied motor units. You have a single nerve that communicates with several different muscle fibers. Those communications occur at the centralmost component of the muscle fiber called the motor plate, allowing for transmission along in both directions of a muscle fiber, thus assuring the most accurate or most fullest amount of coordinated contraction within a muscle. So you may have any questions about tone and motor units at all?
Looks like I'm the only one having questions. Anyway, my question is, the muscle fibers, can they be serviced by multiple neurons?
What? Sorry?
The muscle fibers, can they be serviced by multiple neurons?
Are you talking about a single muscle fiber? Can it have more than one neuron feeding to it? No.
Yes.
No.
Okay. So the motor neuron is very individualized within the muscle.
The motor neuron, just so long as you understand, a motor neuron.
Motor units. I meant motor units, sorry.
Yeah, just so long as you understand that a motor neuron separates and splits into multiple different branches.
Yes.
Feeding into several different muscle fibers.
But one muscle fiber will
But any singular muscle fiber would not receive more than one nerve stimulation to it.
Okay, thank you.
Okay. Okay. Okay, so we've talked already about what normal resting tone is. Okay. So the next thing becomes when you have abnormality within that tone. You can either have hypotonicity, in other words, a reduced amount of tone. You can have hypertonicity, which is an increased or exaggerated amount of tone within the muscle. The other two types of dysfunction you can have are adhesions, where you actually have adhering together of muscle fibers to one another, or you can have contracture, where there's actually been damage to a muscle fiber and there has been a repair process put in place, very often reforming into what is referred to as scar tissue. Okay. So you need to be able to distinguish these four different components. So hypotonicity is where you would have found weakness in a muscle. Very often there is a flaccid feeling within the tissues. and can sometimes or very often be associated with neurological damage. Hypertonicity is an exaggerated amount of tone, so there's an increase. So this is where we're going to feel an increase in tension within the muscle fibers. And then we move to adhesion. Now, adhesion is very often distinguished by maybe sedimentary lifestyle. You can, if a person is not moving and not causing their muscle fibers to glide and function properly, they can fill with adhesion. If they've had some kind of, if they have abnormal hypertonicity in a muscle, that can prevent proper flow of the lymphatic or the extracellular fluids, which can lead to adhesion. They could have a pathological condition that has caused dehydration, and dehydration can lead to insufficient extracellular fluid, which results in adhesions formation. And then you come to contracture, and contracture normally is associated with some form of trauma, whether that trauma be a direct blow or an over-excessive strain or demand put upon the muscle for some reason, usually comes from contracture. So when you're trying to determine what is happening within the muscle, you can use palpation. Palpation, of course, for contracture is very hard. For adhesion is usually smaller components, but still forming to the muscle fiber shape. Hypertonicity is an exaggeration of tone, but not so severe as what you would find in contracture. And then hypotonicity would be a lack of tone within the muscle. So these are the four primary things that you need to be able to distinguish. Ooh, let me see. I thought hypotonicity was a 0 on the Wellington scale. It is a 0 on, it is a 0 on the Wellington scale. 0 would be less than normal. 0 would be hypotonicity, yeah. How can we tell the difference between contraction and contracture? Is the muscle being called upon to do a particular task for some reason? Would be contraction. The separation in the Wellington scale between 4 and 5 just simply is to try and get you to understand and comprehend that a contracture is harder than normal amount of contraction. If you cause a muscle to contract, to lift an object, the palpation that you would feel in that is not as firm as what you would feel in a state of contracture. So that's why there's a 4 and a 5 on the scale for distinguishing those two things apart. Hopefully that answers your question. Let's see. Okay, good. All right. Anything else? Good questions. So hypotonicities, I'm not going to go through it. You guys have read these PowerPoints. We've used them once already. I'm just simply going to ask, is there anybody that needs me to clarify any components as to hypotonicity? Right? The indicators for hypotonicity, of course, would be restricted range of motion on passive, but an equal range of motion, restricted range of motion on active, but an equal range of motion on passive is an indication of hypotonicity. You can then apply a strength test, and if you have hypotonicity, you should theoretically have some loss of strength within the muscle. And you can also palpate the tissue to see if there is lack of tone within the tissues, or 0. Okay. There's several different causes of it. So the things that you would use for identification would be loss of normal tone, loss of active range motion, loss of strength. Somebody got a question?
Yes, me again. And we are talking about the agonist muscle, right?
We're
The
talking
weakness
here in general about tone is what we're talking about, hypotonicity.
Okay, so for example, let's say I perform hip flexion, okay?
Huh?
So if I have a restricted on active, and when I do the strength test, I notice like there's weakness in the quads. We are talking, then it would be the quads, right?
Yeah, it would be a weakness in the agonist, looking at it from that avenue. You could go at it the other way around too, and you could say, I have found a muscle that upon palpation has less than normal tone within it. Is another way you can do it. It's not all, you don't always do everything exactly according to the book. You have to take that concept and be able to apply it in multiple different situations. So either of those are accurate, right?
Mm-hmm.
Okay. So the techniques that we're going to use, now we haven't covered all of these techniques in class yet. We're going to be finishing them off this weekend, but extrinsic treatments that we would use to treat a hypotonicity would be, first of all, from your foundational techniques, Tappament can be used. Intrafusal muscle fiber stimulation is exactly the same as Tappament. The only thing is it is much more precise and accurate. It's targeting a much smaller segment within a muscle. When you're using extrinsic techniques of intrafusal fiber stimulation, you need to move it around and apply it in several different segments within a muscle. Because again, if we go back to thinking about how is tone generated, tone in a muscle is generated by motor units stimulating multiple muscle fibers, right? So if the motor unit is not firing properly, you can stimulate throughout the entire muscle and indirectly cause a single section within the muscle to increase its tone, because the muscle fibers are not isolated to just that one area. You could use other segments within the muscle through the motor unit to cause the contraction, increase tone. So when you're doing intrafusal muscle fiber stimulation, you don't have to be so targeted just at the muscles that appear to be without tone. You can target it around the area as well and still have a positive effect. The same thing with stripping. Is another technique that you can use, stripping and local cross-fibering. However, when you apply these particular techniques, you need to elevate the speed of the application in order to cause the spindle to fire. So it's kind of like either plucking a guitar string or running your finger very quickly and pulling on the spindle as you travel over top of it. So that's how you would use local cross-fibering or stripping technique. And then intrinsics we're going to talk about at this seminar weekend. Seminar weekend or next seminar weekend, actually. Okay. Does anybody have any questions? Oh, I missed something here. The definition between extrinsic and intrinsic. Extrinsic techniques are those techniques that you as the operator are required to participate in to generate the change within the tissues. Whereas intrinsic techniques are those techniques that you are requiring neurological or the client has to play an active role in an intrinsic technique. So they're going to have to call upon their nervous system for some component. That's the difference between them. Extrinsic is done externally from the body. Intrinsic is something that is done internally within the body to alter the amount of tone within a muscle. I guess that would be a best definition for it. Okay. Yes, a PNF stretch, Brian, a PNF stretch would be an example of an intrinsic technique, correct. Okay. Hypertonicity, again, a situation of exaggerated tone within a muscle, resulting in either a reduced range of resulting in a reduced range of motion during active testing, a reduced range of motion during passive testing, and for verification, you should find a rating greater than W3 in tissue palpation. Again, several causes for that to occur. Hypertonicities are usually the cause where you have found there is actually skeletal misalignment. 90% of the time or greater, it is actually involving hypertonicity, pulling the bone or holding the bone in an improper position. Weaknesses don't very often actually cause bone misalignment. It's very important, especially with hypertonicities, that whenever you have a dysfunction occurring where there has been bone misalignment at one end of the muscle or one attachment site, it's very important that you look to the other end of that attachment site to see if in fact there are dysfunctions also occurring at those ranges of motion in those joints. So that's what's referred to as associated dysfunction. Treatments that we're going to use for hypertonicity, we would do it in phases. So the first phase would be general cross-fibering. And then you can go into more specific techniques of stripping, strain counter-strain, focal cross-fibering, ischemic compression. So ischemic compression is a straight direct pressure down into the muscle motor unit, motor plate of a muscle fiber. Strain counter-strain is you palpate for the end segments of a hypertonicity, apply ischemic type compression into the tissues, and then proximate your thumbs, or in other words, bring your thumbs closer together, maintaining that tension, would be strain counter-strain technique. And local cross-fibering is simply friction, but applied to a very specific small area, and there's always tension pushing up into the segment of hypertonicity when you're doing local cross-fibering. And intrinsic techniques, again, we'll cover it next class. So you may have any questions about hypertonicity? So adhesions, adhesions were going to be, can be associated with recent trauma, but prolonged hypertonicity or hypotonicity in a muscle can result in adhesion because of the improper movement of fluids around the muscle fibers. They'll can cause loss of range of motion. There may be patient complaint of pain or inability to perform tasks. May all occur when you have adhesions. Very often you will find adhesions in the presence of hypertonicities, but so you'll very often you'll find adhesions where you're finding hypertonicities as well. The difference between general cross-fibring and stripping. Well, let's start with stripping. Stripping is an application where you start at one end of a muscle fiber, you apply pressure, and you travel steadily through that entire muscle fiber right to its opposite end. That is stripping. General cross-fibring is something where you're not targeting on at the end of the, you're not looking for the end of the muscle fiber. It's applied generally in the area of hypertonicity, and it's a more of a very passive, broad application of pressure down into the bellies of the muscle to try and warm the tissue, separate it apart, and initiate mechanostimulation to the fibers. Does that help to clarify for you? The big thing to remember is stripping is the entire length of the muscle fiber, whereas general cross-fibring is more done with the border, the edge of your thumb, your thenar eminence, and down into the tissues. Strumming the car. Natalie, your explanation of strumming the guitar for cross-fibring, that would be if you are only using, if you were using cross-fibring, localized cross-fibring, for the purpose of trying to stimulate the spindle. That would be more like a fairly quick motion, like strumming a guitar string, where you come off of it. Where you're using local cross-fibring to reduce hypertonicity, it's much slower, and it's more, you're not snapping off of the edge of the tight fiber. You're more so applying a pressure back and forth, kind of like a wave. Whereas for the stimulatory type of application to create tone, you're kind of plucking it more like a guitar string. Hope that clarifies that. Strain, counter-strain. Strain, counter-strain is where you palpate to the two end segments, end points of a hypertonicity, and you're going to apply ischemic type compression down into the tissues at that point, and then you're going to proximate. In other words, bring your thumbs closer together, maintaining that tension. As they get closer and closer together, there's less tension on the spindle, and the muscle ceases to contract. Right? So that would be strain, counter-strain. How does cross? I want you guys to be sure when you're using the words cross-fibring, you're talking about cross-fibring versus general cross-fibring. General cross-fibring is a much broader contact. You shouldn't just use cross-fibring. You should use the words local cross-fibring or general cross-fibring, because when you say cross-fibring, I don't know what you're referencing. So please make sure to always use LCF or GCF, right? Local cross-fibring or general cross-fibring. Otherwise, we're going to get confused. So the difference between local cross-fibring between general cross-fibring and goading is the amount of pressure, really. It's the only main difference between the two. Not the same application. There's heavier pressure in general cross fibering than there is in goating. Okay. All right. Any other questions on that one so far? So when it comes to adhesions, now we need to use techniques to treat adhesions that by applying their mechanical effects. So the techniques for hypertonicity are primarily neurological. The other ones that you guys have referenced to general cross fibering, these are mostly neurological type applications. When it comes to treating adhesions, what we want to do is we want to literally separate apart those fibers, mechanically pull them apart. So the best tool that we have to do that is, actually the only tool we really have to do that is frictioning. So whether that is frictioning as you have been practicing it for the first half of the year, or more specific localized frictioning, where you're being much more precise using what's referred to as transverse frictions across the fibers to try and separate those fibers possibly apart. General cross fibering can have a minor effect on separating muscle fibers. Same thing with stripping. Minor effect, but very, very minimal, those two techniques. The best technique is local cross fibering. Now, some people will actually be using transverse frictions because they don't know the muscle fiber direction maybe very well, and they're going to be applying stripping, what they think is stripping, but in reality, they are really applying transverse frictions. It's just their inability to know how a muscle is designed that makes it effective. So stripping is not really a technique that I would use as a primary tool for treating adhesion. Right? Petrissage for adhesions. Petrissage for adhesions would be like using general cross fibering. It's not very effective. It's just not. It will have some minor benefit, but for a therapeutic point of view, I'm going to be wanting to do more very specific treatment protocols of local cross fibering. Intrinsic techniques, there are no intrinsic techniques that will have an impact on adhesion. Intrinsic techniques are purely neurological. This is not a neurological problem, so therefore they are of no benefit. Does anybody have any questions on any of this component?
Just to clarify, Randy, so local cross fibering, you're going parallel to the tissues, and then transverse friction is transverse to the tissue fiber direction?
Well, local cross fibering, transverse friction, you're right.
Can you guys hear me?
Yeah. Local cross fibering, transverse frictioning are really exactly the same thing. Local cross fibering, the thing that's of importance is you're going transversely across the muscle fibers. Local cross fibering, you're applying pressure up in, for lack of a better description, they're really no, they're not really true. When you're applying local cross fibering, you need to be applying pressure up into the segment of the hypertonicity or dysfunction when you're applying your frictional component, when you're doing local cross fibering. When you're doing transverse frictioning, the pressure up into the segment of hypertonicity or dysfunction is not as important as when you are doing it with local cross fibering. I hope that makes sense. So the difference between the two is transverse frictioning would be the application across the muscle fibers to separate things apart without exaggerated pressure into the segment of dysfunction. Whereas local cross-fibering is going to have compression into the section of dysfunction as well. Does that help clarify?
Okay, that makes sense. Thank you.
Okay. All right.
Yeah, that was helpful.
Good. Anything else? Any guys? Okay, the next one is contracture. Contracture, we treat it exactly the same way as what we would treat adhesion. The biggest difference between adhesion and contracture is contracture is very often going to be associated with some kind of major trauma or dysfunction that's occurred within the tissues, whereas adhesion may not have a severe type of trauma associated with it. The thing that defines the two is we can have adhesion without damage to the muscle fiber. Contracture requires damage to the muscle fiber. So there has to be a healing process occurring already as a result of some form of trauma. But as far as treatment-wise and technique, understanding which techniques you're going to use, you would use the same techniques to treat a contracture as you would to treat an adhesion. The difference would be in the treatment of a contracture, because we have an associated trauma occurring, we have to be much more careful in how we apply those techniques to those areas of trauma. That is more so the factor when it comes to contractures. And again, a lot of things we'll have to take into consideration down the road, such as how old is this? If we're talking about somebody who has a contracture from 6 months ago versus someone who has a contracture resulting from 5 days ago, they're two entirely different situations. Right. Any questions about contracture at all? Okay. So the next thing, you guys all know these already, I'm pretty sure. You understand what a stretch reflex is. That's when the annulospiral gets stimulated due to a muscle stretching in length, sends an impulse to the spinal cord where it communicates directly with alpha and gamma motor nerves, resulting in a contraction back in the muscle. So for your clinical exam, you would be saying things like stimulation of the spindle generates an impulse to the spine, releasing acetylcholine at the alpha and gamma motor neurons, resulting in muscle contraction. Tendon reflex is the exact opposite. Tendon reflex is where the GTOs are located at the musculotendinous junction. So as a muscle contracts, stimulus is sent to the spinal cord where it communicates with an association or interneuron, causing the release of glycine, and glycine blocks your alpha and gamma motor neurons back to the muscle, ceasing the contraction. So those are the two primary reflexes that we work with, stretch reflex and tendon reflex. Anyone have any question on those two? Tissue adaptation. Whenever when you have a hypertonicity in the muscle, there's going to be tension on the spindle. And because there is tension on the spindle, the flower sprays are going to be firing. That's what helps to maintain the tone within the muscle. So when we apply such techniques as local cross fibering, what we're going to do is we're going to apply pressure up into the section of the spindle, and by so doing that, or section of hypertonicity, and by so doing that, we are going to reduce the tension on the spindle. Now, because there is no tension on the spindle, there's no impulse to help maintain the tone. So slowly the tissue starts to adapt to that by lengthening out until it can pick up that's tension on the spindle again. So that says it in a nutshell. That's tissue adaptation. So when we take pressure off of the spindle, tension off of the spindle, the tissues will adaptively lengthen until there is tension once again restored on the spindle. And we refer to that as tissue adaptation. So back to the question that was earlier, what's the difference between local cross fibering and transverse frictioning? Local cross fibering uses this principle of tissue adaptation to help to reduce the amount of hypertonicity in the muscle, whereas transverse frictioning does not incorporate this compression up into the section of hypertonicity. So that's the primary difference between the two. This one uses tissue adaptation. Just straight transverse friction would not use tissue adaptation. The fourth type of dysfunction we have is referred to as neuronal adaptation. So you guys all know about how a neuron normally sits at -70. However, if it has been stimulated for an extended period of time, the body has the ability to adapt that neuron to a lower resting membrane potential, and it will sit it at -60. So the amount of stimulation required to get down to threshold, which is -55, is much less, and as a result, the stimulus along the neuron can happen quite easily and quite quickly. Sometimes that will generate too much tone within a muscle, and it's referred to as neuronal adaptation. So we will use techniques to try and break this pattern, and the technique that we use is ischemic compression, is trying to break this neuronal adaptation that is occurring within the nervous system. All right, so neuronal adaptation is primarily treated through ischemic compression and strain counterstrain. So those are the those are the four difficult. You need to know those four different causes for dysfunction within a muscle. The other thing we want you to know is, of course, we've already talked about this, the mechanostimulation, and how stimulation to the mechanoreceptors under the skin can result in elevated, decreasing sensation of pain and tone within a muscle, because they associate or communicate with association neurons releasing glycine, thus reducing the amount of contraction. So, again, what do you know? Do you guys understand stretch reflex? Do you understand tendon reflex? Do you understand mechanostimulation, neuronal adaptation, or tissue adaptation? Do you guys have an understanding of all these different techniques? If there's any questions, please let me know. So I'm going to run. Okay, good. So in a nutshell, going through the different techniques, goading is a technique that is primarily used to stimulate mechanoreceptors. Therefore, it is primarily used for reducing general sensation within the tissues or reducing pain and preparing the tissues for deeper application of other techniques. So that's primarily what we use goading for. Whenever there's pain in an area, we would apply goading. Okay? When you're applying goading, you make sure that you use the entire surface of your hand. You're not trying to slide on the skin. You're simply trying to warm the tissues and gently affect the underlying contact area. General cross-fibering, also used generally to reduce pain. It has some ability to reduce muscle hypertonicity because it's increasing the amount of pressure. Goading is very light. General cross-fibering is heavier. You're using more of the thinner, the edge of your thinner eminence, the edge of your thumb, and the heel of your hand to create the application. So general cross-fibering is also used to warm the tissues, especially deeper tissues that we want to affect. So you get into local cross-fibering. Local cross-fibering can be used for breaking down of adhesions. It can also be caused to reduce hypertonicity within the tissues. And the big thing with this technique is you're going to apply it at the end of the section of hypertonicity or contracture or adhesion. You're going to apply a little pressure up into the segment of dysfunction and then slowly kind of nibble away at that adhesion or that dysfunction, kind of like trying to nibble away at a frozen pat of butter. So local cross-fibering is going to incorporate tissue adaptation. It's going to incorporate some separation of the muscle fibers from its mechanical effect. And if it's applied close to the tendon, it can generate a GTO firing. But if it's too far away from the tendon, it won't have that effect on it. And then also, because you're applying pressure down into the tissues, there can be some general reflexive hyperemia. Reflexive hyperemia just means you're removing the blood from the area through pressure, and when you release off the pressure, you will see the blood flush back into the area. This is referred to as general reflexive hyperemia. Also, reflexive hyperemia can be a result of microtrauma to the tissues, which causes vasodilation, resulting in increased blood flow. So that's local cross-fibering. Stripping technique. Stripping technique is a technique that is primarily neurological in its effect. You start at one end of a muscle fiber with pressure and travel straight through. Tissue blanching. Yeah, I believe it would blanching would be also a similar, another way of saying the same thing. Tissue blanching. Stripping technique. Stripping technique is where you apply pressure starting at the musculotendinous junction or at one end of the muscle fiber. You're going to apply that pressure, maintaining it through the entire travel to the other end of that particular muscle fiber. Hopefully what you are doing is increasing GTO stimulation, reducing the flower spray, so you're having some tissue adaptation, ahead of your contact site as you get eventually arriving at the opposite end of the muscle fiber. The application is slow and steady. There is no real major mechanical effect other than the fact that there could be some reflexive hyperemia, but that would be the only mechanical effect really involved in it. So what this is going to do neurologically is it's going to reduce the flower spray stimulation within the spindle and increase the GTO stimulation at the tendinous junction, and together they will help to reduce tone. So that is stripping. Anybody have any questions about stripping? Our next one is ischemic compression. So ischemic compression is a technique where what you're going to do is you're going to find the central component of a section of hypertonicity or dysfunction, and you're going to apply your contact into that site. Ischemic compression, you should be applying your pressure into the tissues, monitoring it very carefully. When you feel tension back up onto your finger, that indicates to you that you have achieved the proper pressure that you want. You would hold it at that point for a maximum of 90 seconds. However, in that 90-second period of time, if you find that there is a reduction in the tone, you can increase the pressure just so long as you just maintain. You don't want to go too hard. You just want to maintain that tension up against your contact site. Very important in the application of ischemic compression. You should never apply ischemic compression for longer than 90 seconds. Right? If you hold it for longer than 90 seconds, you could cause denaturation within the tissue. In other words, the tissue could actually start to die. So you have to be very careful of that. So the mechanical effects of ischemic compression are that there's actually a blocked blood supply, which will result in reflexive hyperemia when you release pressure. And there's also the principle that you could be blocking the neurological impulses to the motor plate, thus reducing the amount of nerve stimulation to a muscle. Again, both of these factors can reduce hypertonicity. Now remember, one of the causes of hypertonicity are insufficient ATP available to break the myosin-actin bonds. So the reflexive hyperemia created with ischemic compression can help to produce, generate an increase in ATP presence, thus allowing more ATP to make the connection to break the bonds within the muscle. So those are some factors about ischemic compression. Ischemic compression is very similar to strain-counterstrain. The primary differences are, in strain-counterstrain, you are again going to be seeking out the section of hypertonicity, but this time you are going to use two contacts, one at each end of the section of hypertonicity. You'll apply ischemic compression type application into the tissues. So you put a push down into the tissues with your thumbs, same as what you did with ischemic compression. The difference is now once you have that tension, we want you to bring your thumbs closer together while maintaining that tension. So this is called proximation of your contact points. You shouldn't force the tissue, just allow you to slowly slide together. And again, this will have very similar effects to what ischemic compression did. And again, the maximum application would be 90 seconds. Does anybody have any questions about ischemic compression or strain-counterstrain technique? Okay. Interfusal muscle fiber stimulation, we kind of already covered that already, but interfusal muscle fiber stimulation is done on weak muscles or hypotonic muscles. You can apply it throughout the muscle belly because, again, we're trying to stimulate the spindles to create more motor stimulus back to the muscle, thus increasing the muscle fiber recruitment, it's referred to as. So what we're doing is contacting into the segment of tissue that is hypotonic, doing a relatively quick burst into those muscle fibers, getting the spindles to stretch and fire and sending an impulse to the spinal cord, which will result in increased muscle tone. So that would be interfusal muscle fiber stimulation. And that's where we're going to end, I think, for today. Yep. Intrinsic techniques we're going to talk about at class on the weekend. Does anyone have any questions on anything? So you guys are comfortable, or at least have a general understanding of your techniques and when they're going to be applied. So what you're going to ask you to do is, well, you're going to be expected to know this, yeah, as at not at this quarterly exam, because this exam is known. This section is for the fourth quarter, the last section of your studies. We're not talking about knowing this tomorrow. We're talking about knowing this over the next period of 2 months that we work together. Okay. We will be practicing all these different techniques at the seminar weekend. This is just the introduction to you, but you need to be going through and reading the manuals. Don't just wait until the seminar weekend in order to, I want you to come prepared. So I've read your manuals, read through this PowerPoint a couple of times in preparation for that seminar weekend, because the more you understand, the better off you're going to be long term. Okay? All right. Doesn't look like anybody has any other questions for me. So we're done a little bit early. Anybody have any questions on anything else that they would like clarified?
I have a question in regards to the assessment quarterly exam that we're going to have this Friday. Are we expected to palpate as well, and will we do it through the clothes? Because I understand we're not doing any hands-on massage.
How do you do it in your practice?
In my practice,
how do you do it
like when I do assessment at the moment, well, I usually have like a shorts and tank tops for ladies, or the guys, you know, they just strip down shorts, and then I do all the assessment. And usually once they're on the plinth, I will confirm my findings through palpation.
Then that's what you should do.
Okay, so are we the people that we will assess during exam? Like, are we going to have assessment gowns for them, or should we bring
we have
something
assessment
along?
gowns in the weekend, every weekend. Yeah. Right
okay,
there.
So we can basically lay them on the plinth after that and palpate and do all that stuff.
However you do it, yeah.
Okay, all right.
Yep. Any other questions on that? All right. If not, I guess that is our class for this evening. I'll get this recorded, done, and put up onto the website. No problem.